Throughout my medical career, I've unzipped the chests of over 2,000 patients. I've physically grasped beating hearts, feeling firsthand the stark contrast between a vibrant, thriving muscle and one that is silently giving up. Over the years, the most devastating harm I've witnessed under the surgical lights didn't stem from a lifetime of junk food. It didn't come from a smoking habit or even bad genetics. The culprit was often prescription medication, daily pills handed out by well-meaning professionals that were secretly sabotaging the cardiovascular system. As a cardiothoracic surgeon with a quarter-century of experience, I step in when the damage is done and the scalpel is the final resort. Today, we are going to discuss 5 highly common medications swallowed by millions of adults over 60 every single morning, and the critical side effects that a rushed 7-minute doctor's visit simply misses. My goal isn't to frighten you. My aim is to arm you with the exact knowledge required to demand a higher quality discussion with your primary care provider. Once you cross the threshold of 60, your physiology handles pharmaceuticals quite differently. Your kidneys take longer to filter waste, and your liver's metabolic speed drops. Yet, a typical American senior is juggling 4 to 5 different prescriptions at once, sometimes upwards of 8. We test and approve these chemicals in isolation. But what exactly occurs when you throw a handful of them into an aging system that is already under stress? Nobody pauses to answer that question during a routine checkup. Let me tell you about a patient I'll refer to as Clarence. He was a 74-year-old retired electrician, sharp as a tack, meticulous, and doing everything by the book. He got his daily 2-mile walk in, kept a close eye on his diet, and logically assumed his cardiovascular health was locked down. Yet, Clarence ended up in my clinic following his second major heart issue in a span of just 18 months. He was utterly drained. This wasn't ordinary fatigue, it was a profound, bone-weary exhaustion that sleep couldn't fix. He was being jolted awake at 3 in the morning by severe muscle spasms, and his cognitive sharpness had faded so noticeably it terrified him. He consulted 3 separate physicians and received the exact same dismissal from all of them. "You are 74, Clarence. This is just part of getting older." He endured that reality for 2 solid years. I sat down and looked at his complete medication chart. I checked every pill, every milligram. Within 5 minutes, the underlying issue was glaringly obvious. It wasn't just a single error, but 3 concurrent chemical collisions happening inside him for 24 straight months. I will share the conclusion of Clarence's journey later on, because the way his situation was resolved is the very foundation of why I am speaking to you right now. Now let's talk about the 5 medications. Number 1, statins. If you have celebrated your 65th birthday in the US, there is roughly a 33% probability you are taking one right now. Atorvastatin, rosuvastatin, simvastatin. The brand names vary, but the internal mechanics are identical. Let me be perfectly clear. Statins are lifesavers. For patients with established heart disease, the data is undeniable. I have written thousands of prescriptions for them, and I absolutely stand by their efficacy. However, there is a significant catch usually buried deep in the fine print. Statins work by inhibiting what's known as the mevalonate pathway. The issue? That pathway doesn't exclusively manufacture cholesterol. It is also responsible for generating coenzyme Q10 or CoQ10. That one detail changes the entire picture. CoQ10 is the premium fuel your cardiac cells rely on to pump. Think of it like motor oil. Drain it, and the engine starts sputtering, running rough, and eventually wearing out. A widely repeated meta-analysis from 2005 demonstrated that statins deplete CoQ10 levels in the blood by 30 to 50%. That is up to a 50% reduction in the exact organ that requires it the most. For a real-world patient, that translates to relentless fatigue that sleep won't cure, weak muscles, cognitive haze, and in a notable portion of people, a measurable drop in cardiac output. Clarence had been taking a high-dose statin for 24 months, 2 full years of his heart operating on an empty tank. Here is the part that should make your blood boil. Testing for CoQ10 isn't part of standard medical guidelines. Many insurance companies outright refuse to pay for it. Because CoQ10 is available over the counter, it holds no patent, yields no massive profit margins, and offers zero financial motivation for anyone to integrate it into standard care protocols. I am not suggesting a grand conspiracy, I am describing a system that lacks the incentive to ask an inconvenient question. The solution is straightforward: 100 to 200 milligrams of CoQ10 a day. The Q-Symbio trial clearly proved that supplementing it yielded significant improvements in heart failure patients. So the question to write down for your next visit is this: Should I be supplementing CoQ10 alongside my statin? Do not ask if you should quit your statin, just ask about the addition. Pill number 2 often catches people off guard because it doesn't look anything like a cardiology drug. That is precisely what makes it so hazardous. Ibuprofen, naproxen, diclofenac, the standard cheap NSAIDs found in virtually every bathroom cabinet in the country. The common assumption is that since inflammation is harmful to the heart, an anti-inflammatory like ibuprofen must be neutral at worst. That reasoning is dangerously backward. NSAIDs function by blocking COX enzymes, but COX-2 specifically is responsible for producing prostacyclin, which is your blood vessel's built-in defense mechanism. It keeps the arterial walls pliable and stops fatal blood clots from forming. Block COX-2 and you strip away that vital armor. At the same time, taking NSAIDs routinely bumps your blood pressure up by 3 to 5 millimeters of mercury on average. 3 to 5 points might sound modest, but if you are over 60 and your arterial walls are naturally losing elasticity, that constant elevated pressure compounding over the years severely heightens your risk of a stroke. The FDA actually mandated a black box warning for NSAIDs back in 2015, explicitly highlighting the risk of heart attacks and strokes right there on the label. Clarence was swallowing ibuprofen every single day for 2 years. His physician was aware, yet no one raised a red flag about his cardiac risk. If you suffer from chronic joint pain, inquire about topical NSAIDs. Prescription gels provide the exact same localized anti-inflammatory relief, but with 90% less absorption into your systemic bloodstream. For underlying chronic background inflammation, curcumin paired with piperine has solid clinical backing. Additionally, taking 2 to 3 grams of omega-3 EPA and DHA daily offers far better cardiovascular protection than most people realize. The Reduce It trial revealed a staggering 25% drop in major cardiovascular events using high-dose omega-3s. That is a number you need to know. Again, do not abruptly stop a prescribed anti-inflammatory without consulting your physician. The objective here is a more informed discussion, not playing doctor yourself. Pill number 3 is something the medical community took a shockingly long time to fully grasp because it doesn't appear to have any link to the heart. Most people buy it right off the shelf and swallow it with their morning brew without a second thought. I'm talking about proton pump inhibitors, or PPIs. Omeprazole, pantoprazole, lansoprazole, roughly 15% of all American adults are on these, many for years or even decades. Here is what often gets overlooked. Your stomach acid isn't a design flaw, it's a vital gatekeeper. You absolutely need it to absorb vitamin B12. If you suppress that acid long-term, you effectively shut down your B12 intake. Why should a heart surgeon care about B12? Because it is the primary tool for processing homocysteine, an amino acid that, when left to accumulate, directly corrodes your arterial walls. High homocysteine is a major independent risk factor for heart disease. In some research, it's just as dangerous as high cholesterol, yet it's frequently ignored in a standard blood panel. A 2013 study in the journal Gut discovered that long-term PPI users have B12 levels 30% lower than those who don't take them. Remember, after 60, your body already struggles to absorb B12 naturally. Adding a drug-induced deficit on top of an age-related one is a recipe for disaster. B12 deficiency manifests as exhaustion, cognitive slips, and a subtle tingling in your extremities that worsens so slowly you might not even notice. In severe cases, it can cause permanent nerve damage, all because of a heartburn pill taken for a decade without anyone checking your levels. But the depletion doesn't stop at B12. PPIs also drain your magnesium, which is a cofactor for over 300 different enzymatic reactions. For your heart, magnesium is the electrical stabilizer that keeps your rhythm steady. A deficiency is tied directly to arrhythmias and those painful 3 a.m. leg cramps. In Clarence's case, his B12 was dangerously low, and his magnesium was at the very bottom of the normal range. Technically okay, so no one had flagged it. If you're on a chronic PPI, ask for your B12 and magnesium levels to be tested. Inquire about a plan to eventually taper off. For B12, look for methylcobalamin, 1,000 micrograms taken sublingually. This goes under the tongue and bypasses the stomach's absorption issues entirely. For magnesium, aim for 400 milligrams of a chelated form daily. It's far better absorbed than the cheap magnesium oxide found in drugstores. And whatever you do, don't quit a PPI cold turkey. Your acid will surge back worse than before, causing a rebound effect. You have to step down gradually. Think about the combination Clarence was facing: a statin draining his CoQ10, an NSAID stripping his vascular protection, and a PPI blocking his B12 and magnesium. 3 medications, 2 years, and 0 dots connected. Every specialist focused on their own narrow lane, and no one looked at what the cumulative effect was doing to his body. Now we have 2 pills left. These represent the areas where most physicians have had major blind spots for a long time. Pill 4 is a medication that stops dangerous clots while simultaneously accelerating a process I've witnessed with my own eyes on the operating table. And Pill 5, that involves a recommendation I personally gave for 15 years that the latest data suggests was wrong. I'll tell you exactly what I told my own patients when I finally saw what the evidence was saying, and believe me, it wasn't an easy conversation to have. Pill number 4 is Warfarin. It has been around since the 1950s and remains one of the most heavily prescribed blood thinners for patients over 65. Whether it's for atrial fibrillation, deep vein thrombosis, or mechanical heart valves, Warfarin is the standard of care for millions of people, and it does exactly what it's supposed to do. It stops lethal blood clots. It prevents strokes in AFib patients. I am absolutely not arguing against its effectiveness. But here is the crucial detail that your rushed 7-minute consultation will almost certainly skip over. Warfarin functions by blocking vitamin K. The problem is, there are 2 distinct types of vitamin K, and this medication cannot differentiate between them. Vitamin K2 activates a specific protein whose entire purpose is to stop calcium from building up inside your arterial walls, ushering it into your bones instead. Take away that K2 activity and calcium starts to drift. It embeds itself into your blood vessels. Your arteries grow stiff and heavily calcified, much like old plumbing pipes slowly choking on mineral buildup. Because Warfarin blocks K2 right alongside K1, it effectively dismantles your body's main shield against arterial calcification while it's busy preventing clots. A 2019 study published in the Journal of the American Heart Association revealed that long-term Warfarin users experienced a severely accelerated rate of coronary artery calcification when compared to similar patients taking newer generation blood thinners. Keep in mind, these were patients whose physicians were actively trying to safeguard their hearts. As a cardiac surgeon, I know firsthand what calcified coronary arteries look and feel like. That stiffness complicates absolutely everything: the operation itself, the healing process, and the ultimate long-term prognosis. So, does this mean patients on Warfarin need to throw their pills in the trash? Absolutely not. Leaving atrial fibrillation untreated comes with roughly a 5% annual risk of a stroke, which is a danger you cannot dismiss. What it does mean, however, is that you need to ask 2 highly specific questions the next time you see your doctor. First, considering the newer blood thinners available today, is Warfarin still my optimal choice? Drugs like apixaban and rivaroxaban simply do not interfere with vitamin K2 in the same destructive way. Second, has anyone checked my coronary artery calcium score? This is a basic low-radiation CT scan that provides a crystal-clear image of the current state of your arteries. It is arguably one of the most underutilized cardiovascular risk tools we have. A single scan reveals exactly what is happening inside your chest and can drastically alter your treatment path. Now, the 5th pill. This is the toughest one for me to address. Not due to complex science, but because I personally pushed it for years to individuals who placed their trust in me. I backed it without hesitation, and I was incorrect. Calcium supplements. If you happen to be a female past the age of 60, it's highly likely at least one physician instructed you to protect your bones with calcium. 1,200 milligrams daily, consumed with a meal. It is such a standard practice, it barely feels like medical advice. It just feels like basic logic. Then, in 2010, the British Medical Journal released a meta-analysis that froze me in my tracks. 15 randomized controlled trials, nearly 12,000 participants. The finding? Supplementing calcium without vitamin K2 and D3 led to a 30% spike in the risk of cardiovascular events. 30%. Imagine a room filled with 100 women loyally swallowing their calcium pill every day because their physician advised it. Roughly 30 of those women might be substantially elevating their risk of a heart event, all while convinced they are making a healthy choice. We call it the calcium paradox. When you take isolated calcium without K2 and D3, it floods your bloodstream in an intense, rapid wave. Your body has no idea how to process that sudden influx, so it dumps a large portion of it straight into your arterial walls. It's the exact same calcification issue we just covered with Warfarin, but triggered directly by the supplement itself. You swallow a capsule to fortify your skeleton, and it ends up stiffening your blood vessels instead. Why hasn't the medical establishment entirely overhauled its guidelines? Because walking back a directive handed out to tens of millions of people over 2 decades is a bureaucratic nightmare. There are massive legal liabilities and vast corporate interests tied to calcium products. It is much simpler to slip a quiet caveat into the literature than to publicly announce, "We made a mistake." For the initial 15 years of my career, I handed out calcium recommendations to senior female patients automatically. A 68-year-old woman shows minor bone density decline? I'd reflexively say, take calcium and vitamin D 1200 milligrams with dinner. I was executing exactly what my training dictated. When I finally digested that BMJ data, I truly sat in silence. I pictured every single patient I had ever given that instruction to, every woman washing down that pill each morning. I didn't feel guilt. I couldn't have grasped information that wasn't available to me yet, but I felt an overwhelming sense of responsibility. A responsibility to guarantee the next person walking into the clinic gets the full story. That is the exact reason this dialogue is essential and why I am recording this. If you currently take a calcium supplement, do not suddenly quit, particularly if you have documented bone loss. Instead, pose this query to your physician. Do I need to incorporate K2 and D3 alongside my calcium? For the vast majority, the science-backed response is yes. Specifically, K2 in the form of MK7 at 100 micrograms a day alongside a minimum of 2,000 IUs of D3. Some individuals require higher doses depending on their lab results. And whenever feasible, seek your calcium from food first. Dairy, dark leafy greens, tiny fish with edible bones. Let the supplements act as a bridge for the gaps, not the main supply. Up to this point, I've focused on what these pharmaceuticals strip away. Let me take a brief moment to outline what authentic cardiovascular support actually resembles past the age of 60, because it isn't overly complex and mostly doesn't involve a prescription pad. Omega-3 fatty acids, 2 to 3 grams of EPA and DHA daily to lower triglycerides, drop whole-body inflammation, and preserve flexible blood vessels. Magnesium in a chelated form, 400 milligrams daily. As we age past 60, our dietary intake drops, but our body's requirement doesn't shrink. It stabilizes your heartbeat, your blood pressure, and your sleep cycles. Curcumin paired with piperine. This boasts legitimate clinical backing for long-term cardiovascular inflammation, not like ibuprofen, but for the subtle, chronic swelling that quietly fuels heart risks over decades. The research is highly convincing. Nattokinase, derived from fermented soybeans, shows great potential for maintaining clear blood flow and breaking down excess fibrin that leads to clotting. Taurine fortifies the cardiac muscle itself. Aged garlic extract carries substantial data, proving it aids arterial elasticity and healthy blood pressure. Both boast extensive safety profiles. I am not calling these magic cures. They do not substitute necessary pharmaceuticals, but they represent the essential building blocks your system requires to function smoothly, which often get pushed aside. So here's the single action I want you to take before your next medical visit. Document every single prescription, every over-the-counter vitamin, and every exact dosage. At the very top of that paper, write down 3 words. What am I losing? Every pharmaceutical comes with a trade-off. You have the right to understand yours. Statins drop cholesterol but drain CoQ10. PPIs halt acid but block B12 and magnesium. Warfarin stops clots but speeds up arterial hardening. Calcium supplements defend bones but, under the wrong circumstances, turn arteries to stone. None of these side effects automatically dictate that the pill is wrong for your body. What they mean is that the medical discussion is completely inadequate without mentioning them, and you deserve that complete discussion. Let's return to Clarence. After scrutinizing his entire chart, I sat with him for 40 minutes. Not a rushed 7 minutes, 40. We went over every pill, every dose, every chemical interaction. I then personally contacted his cardiologist and his primary care physician. We constructed a cohesive strategy together. We added 200 milligrams of CoQ10 daily. His critically low B12 was addressed instantly with sublingual methylcobalamin. We introduced chelated magnesium. His daily oral ibuprofen was swapped out for topical diclofenac gel, giving him the exact same joint relief with 90% less systemic circulation. His primary doctor initiated a slow taper off the PPI. We also added K2 and D3 to his existing calcium regimen. We performed no dramatic interventions, no invasive surgeries, and introduced no breakthrough drugs. We merely stopped robbing his heart of its necessary operational fuels and replenished the tanks. That was it. 6 months later, my phone rang. It was Clarence. He told me, "I feel like myself again." For the first time in 2 solid years, the crushing exhaustion had vanished. Those 3 a.m. leg cramps had ceased within the first month. His follow-up cardiac exams revealed a measurable enhancement in his heart's function. His primary physician called me, genuinely puzzled. Clarence's recovery completely defied the anticipated downward trajectory. Absolutely nothing had changed except that the entire picture was finally addressed. That is what continues to shock me the most after 25 years in this field. It isn't the intricate complexity of what went wrong, it is the sheer simplicity of what helped. A handful of precise supplements, a medication swap, and a single 40-minute dialogue that his 3 prior doctors simply hadn't carved out the time for. The medications on this list are not the villains. The doctors who prescribe them are not negligent. The fundamental flaw lies in a healthcare infrastructure that rewards writing the prescription while offering zero mechanism to reward the follow-up. A system with no time to ponder. What is this specific combination of drugs quietly doing to this patient over the next 2 years? You cannot single-handedly change the medical establishment today, but you can absolutely walk into that exam room holding your list with those 3 vital words written at the top. And frequently, that is enough. If this message resonated with you, please share it with someone juggling multiple prescriptions, whether it's a parent, a spouse, or a friend who has been convinced their fatigue is just a natural symptom of aging. It very well may not be. Everything we've covered today is anchored in published research and direct clinical experience. However, your situation is completely unique. Bring these points to your physician before altering any regimen. This is the starting point of a conversation, not a substitute for medical supervision. Take care of your heart. It has been diligently beating for you every single second of your existence without ever requesting a break. The absolute least we can do in return is pay attention.